Good morning. Welcome to another edition of the Ministry of Health's Virtual Media Conference, where we provide you with current and accurate information on the Ministry's COVID-19 response. Today we have with us the Honorable Terence Dayal Singh, Minister of Health, Dr. Roshan Parashram, Chief Medical Officer, Dr. Miriam Richards, Principal Medical Officer Institutions, and Dr. Avery Hines, Director of Epidemiology at the Ministry of Health. I'm Candice Alcantara, Manager Corporate Communication at the Ministry, and I will moderate this morning's media conference. We begin with the clinical update from Dr. Roshan Parashram.
Hi, good morning, Honorable Minister, Dr. Richards, Dr. Hines, members of the media, members of the viewing and listening public. So I'll first give the clinical update for this morning. So as of 30th of April, 2021, total persons tested so far, 131,207. New positives over the last 24 hours, 326. Taking our grand total up to 10,824 positive cases since the 12th of March 2020. Our total recovered patients now stand at 8,481 with a total active caseload of 2,174. The total persons in home isolation now stand at 1,651 and those in state quarantine at 251. Those at step-down facility 24 and persons who are in hospital at this time, 173. So a little later on, Dr. Richards will go into full detail as to those who are in hospital. She will give the occupancies and the numbers, and she will also give those details as to who is in quarantine facilities. Just to end my brief update this morning, as the Honorable Prime Minister would have indicated, and in alignment with his guidelines of continuing the vaccine drive using the SII AstraZeneca doses, just to confirm, and we have been getting calls at the Ministry, that persons will be getting their second dose of the AstraZeneca vaccines. So those persons who would have had their first dose, be assured that you will be getting your second dose of AstraZeneca from the same vaccine as you did for the first dose. So just to give you that.
Thank you very much, CMO, and thank you for reassuring the public, especially those who received the first dose of the vaccine. We go now to Dr. Hines for the epidemiological update.
Thank you, Ms. Alcantara. Good morning to the Minister, Dr. Parashram, Dr. Richards, members of the media, members of the viewing and listening public. If we can have the first slide, please, we'll go directly into the epidemic curve for this epidemiologic update. Next slide, please. And I believe the slide after that. Right, excellent, right there. So, as you can see with the epidemic curve, we're comparing a couple of things at this point. Looking at the gray bars at the left-hand side of the curve, what we see is the figures for 2020, comparing now that peak in 2020 with what's happening all the way over on the right-hand end, where we have the colored bars, the purple color representing the month of April. We see that we are now getting numbers that meet and surpass some of the higher figures that we would have had at the peak of the last big wave in the August to September timeframe. And although we do see that we may see smaller numbers towards the right-hand end, we do know that additional data will still come in, and those figures, the heights of those bars may change. So the main message from this particular curve is that we are seeing steadily increasing numbers. They've been increasing from the orange bars in March all the way through to April, and that rolling dotted line that represents that 7-day rolling average, that has also been steadily increasing. And the measures that we are now recommending are those that we want to apply to slow this upward trend. If we take a look at this in the next slide, aggregating the data by week and looking at the positivity, we see that, again, that upward trend is noted, and the background, that salmon-colored graph or area in the background, actually shows the rising positivity of the samples that we are getting. Rising positivity meaning out of every 100 samples we get, what percentage of those are positive for COVID-19. At this point, the positivity is about 27%. We're seeing it continually increasing. It's been increasing since week 10, and this indicates that there are higher levels of viral prevalence in the population, and you're seeing that reflected in the proportion of people testing positive for coronavirus when they present with respiratory illness or when they present after having been identified as a contact. Next slide, please. Looking at that age-sex distribution, we do see that the pattern maintains or holds itself, where that younger mobile age group constitutes the vast majority, about 55%, and that 55% is a little more skewed towards the males and females. The overall number of positives being distributed nearly 50-50, 52% male and 58% almost female. So that has not changed. The distribution continues basically as it is. And next slide. The fatalities also maintain a 3-to-1 sort of proportion of men versus women among those who have passed on. Also of note, the prevalence of what we call the comorbidities, those coexisting chronic conditions, in the people who have passed on. We've noticed that at least about 80% of them have one or more of the various comorbidities, with diabetes, hypertension, and ischemic heart disease being the most common of those. Next slide, please. Looking at this, what we are portraying here is the number of cases that we see by county from one epidemiologic week to the next. So each group of bars represents a county. The counties are labeled on the x-axis. The height of the bar represents the number of cases, and going from left to right, for each county, we see the aggregate number of cases from week 8 to week 17. There's an asterisk next to week 17 because week 17's data isn't yet complete. Today is part of week 17. We don't have the data in from today yet. So while we see that upward trend all the way through to week 16, don't be fooled by the fact that week 17 so far in some places appears to have fewer cases. We'll have to wait until the actual complete week's data is in before we can say for sure whether week 17 did show any slowing. At this point, we're still seeing that overall upward trend, and that overall upward trend is a cause for concern. Next slide, please. Looking at the distribution of the cases, this is what we call a Choropleth Map. It is one that shows the numbers of cases in various communities, and we would see that we have communities in every county affected, and the ones that are the more densely populated, or the ones with the bigger populations, are at this point seeing higher numbers of cases. This distribution across the country, and the demonstration of this really is just to remind everyone that at this point, with basically widespread community transmission, at any point in any part of the country, you are expected to be following all of the guidelines with respect to reducing your risk, because the risk is widespread. Let's move to the next slide. This represents just the distribution of those 328 cases that you would have seen on April 29th. And you do see that they've found again in every county. St. George West, that's the Northwest Peninsula up top, and St. George Central having a particularly high concentration. St. George East, so that's all the way along that east-west corridor, having lots of cases. Then Caroni, with its sort of continuing level of new cases on a day-to-day basis. Victoria and St. Patrick, there's actually some increased activity in St. Patrick. And River Mayaro, which is over on the right bottom end, and up top on the right top end, that's St. Andrew, St. David, so Sangre Grande, River Mayaro, Rio Claro, all of those areas seeing cases. So that was the distribution just of those cases for the 29th. And if we go to the next slide, we see that the distribution for the next day is basically the same. So there's continued transmission, there's continued detection in all of these places from one day to the next. And the widespread nature of this transmission is what we are now attempting to put a damper on by reducing contact probability. And the contact probability is the probability of an infected and infectious individual coming into contact with a susceptible, not infected person and transmitting the illness. The extent to which we can reduce that by employing all of the public health measures is the extent to which we will be able to apply a braking force, a slowing force to this widespread community transmission. I believe that's the last slide. Just roll forward. That's it. So with that, I'm going to turn you back over to Ms. Alcantara.
Thank you very much, Dr. Hines. And we go now to Dr. Richards for an update on the parallel healthcare system.
Okay, good morning. Thank you very much, Ms. Alcantara, Honorable Minister, Chief Medical Officer, and of course my colleague, Dr. Hines. This morning I will be focusing, good morning to all members of the media as well as to members of the listening population. This morning I will be focusing on basically three areas, which would be an expansion of the statistics provided by the Chief Medical Officer, as per Media Release 710, dated 4 p.m. on the 30th of April 2021, as well as a summary of the breakdown of the statistics in the parallel healthcare system, specifically with respect to the hospital occupancy levels, which have been cause for increasing concern over the last 2 weeks, and a brief summary on the ongoing status of repatriation exercises. So firstly, I will just expand on the CMO's clinical status update with respect to the parallel healthcare system. As CMO indicated, there were 173 COVID-positive patients in 5 of the 7 hospitals in the parallel healthcare system as of 4 p.m. yesterday. At the Covert Hospital and Multi-Training Facility, there was a total of 116 patients, with 8 requiring ICU level care and 10 requiring HDU care. At the Cora Hospital, there were 36 ward level patients. At the Scarborough Regional Hospital, 20 ward level patients. And at the Signal Hill Hospital, 1 ICU level patient. At the step down or transition facilities, at the Uidebe facility, there were 11 persons, and at Tobago, 13 persons requiring step-down care. With regards to the quarantine centers, there were 251 persons undergoing state or state-supervised quarantine at 13 out of 15 facilities. And now I'll move on to the actual breakdown in terms of the hospital occupancy levels as per the 30th of April 2021, and an update as of 10 a.m. this morning on the 1st. We have been noticing between weeks 14 to 17 a significant increase in the overall occupancy of the hospitals in the parallel healthcare system. At present, and up until yesterday afternoon, 5 out of 7 of the hospitals in the parallel healthcare system were in operation to manage COVID-positive patients. As you would recall, in February, a decision was taken to remove ARIMA from the grid, given the low number of persons COVID-positive and COVID-suspected cases that were present in our population. However, we have noticed, especially in the last week, the percentage and the overall occupancy of the hospital system increase actually up to a maximum of 50%. We've also noted a significant increase in the occupancy of the ward level persons, which has vacillated between 37 and 50% in the middle of the week. The ICU rates have also increased, going up to 40%, as well as high dependency rates going up to 25%. Now, it's important to note that the parallel healthcare system is a resilient system that was the Ministry of Health's response to the COVID-19 pandemic. However, given the increasing number of cases on a daily basis, roughly the rolling average over the last 7 days is somewhere in the vicinity of 191 cases per day, we need to remember that of that, approximately 10% of cases will require hospitalization and a hospital bed. That means for every 100 positive cases, 10 persons need to be admitted to a hospital in the parallel healthcare system. It means as well that in terms of how ill these patients are and the severity of their condition, that even though we are admitting 10 persons for every 100, we are only discharging 2 for every 100. So there is a net gain of 8 persons per 100 positive cases in the hospitals of the parallel healthcare system on a daily basis. If we continue on this trend, especially given the recent numbers, 326 per day, 328 per day, we will not have the parallel healthcare system available when we really need a bed for yourself, for your co-worker, for your family, and others. The Ministry of Health had, of course, contingency measures in place to accommodate for increases in the number of COVID-19 cases. However, this is not a panacea. This is a contingency measure. And yesterday we activated or reoperationalized the Arima General Hospital and added 67 additional beds to the grid. It is important to know that overnight, 10 of those beds were used up. So between yesterday afternoon and 10 a.m. this morning, we had 10 patients being admitted into that facility. We have also increased and operationalized additional beds at the Covet Medical and Multi-Training Facility, ward-level beds, ICU-level beds, and high-dependency unit beds. And again, these beds are quickly becoming occupied with ill COVID-19 patients. At the Augustus Long Hospital, which is run under the SWRHA, that hospital has now been transitioned to treat confirmed COVID-positive cases. So there are 48 additional beds to treat confirmed cases while we manage this increased occupancy. As of 10 a.m. this morning, the overall hospital occupancy is 24%. But that decrease is really only because we have added 67 beds at Arima and another 50 at Covet, which increases the overall capacity of the system. Had it not been for these increases, we would actually be closer in the range of 37 to 40% in terms of the hospital occupancies. The ward level bed capacity is actually at about 42%. With ICU at 21% and HDU at 25%. It's important to know that we are seeing the greatest rate limiting factor in this response to the pandemic now at the level of the hospitals and especially the ward level patients. What we are noticing from a clinical perspective is that persons are presenting to hospital very ill, especially those with coexisting medical conditions. And we are seeing a deterioration from ward-level sorts of care to ICU and HDU care. And of course, this has been one of the reasons why we saw the increasing trend in terms of morbidity and mortality, as Dr. Hines just explained. I'm appealing to every member of the population to please exercise personal responsibility in how we prevent COVID-19. Again, this current situation stands to test the resilience of the parallel healthcare system. We urge the population to please pay attention to these growing numbers. Please pay attention to not just the increase in the number of cases, but the increasing number of persons that are being hospitalized. The parallel healthcare system will not be here for you when you need it if we continue this sort of increasing trend. Just to close, I just want to give a very quick summary of the ongoing repatriation exercises. We had a successful exercise on the 30th, on the 29th of April with 136 returning nationals from New York. And we have another exercise that is ongoing with the return of 25 persons from St. Vincent and the Grenadines via the Galleon's Passage. That vessel is due to be docked at the Port of Spain port at approximately 12:31 p.m. and all arrangements are in place. As I close today, I once again appeal on behalf of the government, on behalf of the Ministry of Health and the team that is present here today, to all members of the population to please continue your COVID-19 mitigation measures or your prevention measures. Please wear your mask, watch your distancing, wash your hands, avoid congregation as required. We are appealing to everyone. And also, if you are unwell, please seek medical attention urgently and isolate yourself at home. If we continue along this trend, we will not have a parallel healthcare system available for us when we need it most. And we, the population and the people of Trinidad and Tobago, will suffer. Thank you very much this morning for your attention, and let's work together to keep Trinidad and Tobago safe.
Thank you very much, Dr. Richards. And we go to the Honorable Terence Dayal Singh, Minister of Health.
Thank you. Thank you very much, Candice. Good morning to the Chief Medical Officer, Dr. Parasram, Dr. Richards, Dr. Hines, ladies and gentlemen of the media, ladies and gentlemen in Trinidad and Tobago. Ladies and gentlemen, I want to start off by echoing what Dr. Richards ended with. If we continue at this rate of hospitalizations, we will not have space for persons who are ill. Ladies and gentlemen, we have called this position on ourselves, and it is up to ourselves to retrieve the position. Dr. Richards gave us some sobering statistics. That is, for every 100 cases, 10 persons are being admitted, but only 2 are being discharged. Yes, we can add more beds. Yes, we could add more hospitals, but there is a limit to the human capacity to man these beds. There is a limit to the number of doctors and nurses in Trinidad and Tobago. So whilst Dr. Richards can speak to a decline in hospital capacity from 37% to 24%, that is only because we added more physical space. But we are not adding hundreds more doctors, hundreds more nurses, and it is this same human resource that we have to depend on to vaccinate the population. The point I'm trying to make is that if the population does not work with the measures, and forget this argument about public and private space, the COVID virus doesn't discriminate about public and private space. That is academic, and that's for the lawyers. I am speaking to Trinidad and Tobago. Last night and this morning, we got some very disturbing news and videos about hundreds of people congregating in the Etihad grounds to buy food, in Crossing San Fernando, in the Savannah, in the Curab Junction. This is not the time for discerning members of the public to be congregating by your hundreds to buy food. We are asking people to use the term that Dr. Hines has used, shelter in place. Only come out now, as we did last year, to go to the pharmacy, to go to work, to go to the grocery. Cook at home. Cook at home. The vending, the crowds that were congregating in Etihad grounds, in Crossing, and all other places where food is being sold, will not bring us to the place where the numbers start to plateau and then hopefully come down. So I just want to plead with people again not to congregate. In one night yesterday, we had to ramp up our dialysis facilities in the Arima Hospital. We currently have 10 people on hemodialysis already. 10 people already. And if we continue at this rate, people who need it 2 to 3 weeks from now will not have a dialysis chair. What are we going to tell those persons? How do we explain to families that the parallel healthcare system, which has performed admirably, cannot provide a dialysis chair because we went to Etihad grounds to buy food, or crossing, or Curup Junction? Now is the time to shelter in place. So I'm hoping that that message gets through this morning, bearing in mind that our human resource is finite. It is finite. And I want to make a plea on behalf of healthcare workers who are again rising to the challenge that healthcare workers are human beings. They are not robots. They can't work 24 hours a day, 7 days a week. They need to rest. They have families too. They have children too. So let's again think about our healthcare workers, for whom I have the deepest respect and admiration. But don't take advantage of our healthcare workers again. So that's my plea this morning. My other task this morning is to announce the restart of our vaccination program from Monday the 3rd of May. Candice, is Monday the 3rd? Yeah? Yes. Monday the 3rd of May, in accordance with the Honorable Prime Minister's suggestion. I want to echo what Dr. Parasram has said. The 42,000 odd persons who have been vaccinated, your second dose will be administered to you as we get in more and more vaccines. If we could have this slide put up so we could show persons where these sites are and what the plan moving forward is. Good. So these are the designated COVID-19 vaccination sites that will be available from Monday 3rd. Under the ERHA, there will be 5 locations: Mayaro, Rio Claro, Sangre Grande, Toco, and under their auspices, the mass site at the National Racket Center, which was a huge success. So 5 sites under ERHA. Under North Central RHA, 6 locations: Arima, which everybody is familiar with, Chaguanas, La Hoqueta, St. Joseph, we added St. Helena, and now under NCRHA, we are adding a mass site, which is the UTT campus, Monroe Road, Uriah Butler Highway in Charleville, Chaguanas. So they will also have a mass site for the first time under NCRHA. Under Northwest RHA, 5 locations: Barataria, Diego Martin, Carenage, Mova, and I think the most successful mass vaccination site, which got rave reviews, and they should get an Oscar and an Emmy and a whatever, the Paddock of the Queen's Park, Savannah. Southwest RHA, which serves the biggest chunk of the population, I think they serve a few 100,000, 10 locations: Couva, Freeport, Laramine, Marabella, Point Fortin, Princestown, Siparia, South Oropouche, St. Madeleine. So a couple new health centers have been added, and they are going to be adding for the first time a mass site in Sapa, the Southern Academy for the Performing Arts in Todd Street, San Fernando. TRHA will stick with their 3 locations. We have had talks with Dr. Tiffany Hoyt, and they will alert the Tobago population. We had a meeting with them last week, Thursday, how they will proceed. But for now, they are going with Canaan, Roxborough, and Scarborough. So we have upped the number of locations initially from 21. Then we added Mova and Carenage, we took it to 23. We are now starting this phase with 29 locations, inclusive of mass vaccination sites in all 4 RHAs in Trinidad and Tobago. Later on today, the phone numbers and WhatsApp numbers will be posted on the Ministry of Health's website. Once they are posted today, You can call or WhatsApp your appointments. It is going to be an appointment system from Monday. We are asking persons not to walk in. You may be disappointed. A note on how to work the system. Once you make WhatsApp contact with one of the lines, please, because we observed this the last time, please don't make WhatsApp appointments on all the lines. That just gives us more work. And please work with us. Once you make one WhatsApp appointment, your WhatsApp appointment will be registered and you will be called. So don't make multiple WhatsApp appointments for one person. We are also asking persons, because we noticed this, many persons made appointments and then simply did not turn up for the appointments. If you are ill or whatever, yes, don't turn up, because once you have a fever or anything else. But once you make an appointment and that space is booked for you, we can't reuse it for someone else. So try and stick to your appointments as long as humanly possible. Who are we going to be vaccinating? Now, we have opened and liberalized the criteria in conjunction with talks with the Chief Medical Officer. In the first phase, we were going after solely healthcare workers and persons over 60 with NCDs. We have slackened that and broadened that a little bit. So who can make appointments? Now, it is persons over 60 with or without NCDs. So if you're a healthy 62-year-old, a healthy 72-year-old, you can make your appointment. So over 60 with or without NCDs, all this will be in the public domain from later today. We are also tackling, with the approval of the Chief Medical Officer, those under 60 with NCDs, including asthma, because asthma is an NCD. And COVID affects your respiratory system. So if you're a 55-year-old diabetic, a 45-year-old hypertensive, a 35-year-old asthmatic, you can make your appointment. What we ask is that you walk with some proof that you are, in fact, an NCD patient. A letter from your doctor stating you're asthmatic, diabetic, walk with your medication in your name, some kind of proof that you are, in fact, an under 60 with an NCD. So walk with your medicine bag with your name and your ID, a letter from your doctor stating that you are diabetic, asthmatic, hypertensive, or whatever. So just to recap, from Monday, and the names of these sites and phone numbers and WhatsApp numbers will go up on the Ministry of Health website. It will be on social media. It will go out to traditional media today. We have 29 locations available for you, as I indicated, around the 5 RHAs. Each RHA in Trinidad will have a mass vaccination site. The mass vaccination site at Queen's Park, Savannah, at their peak, were doing about 2,000 vaccines per day, which is a phenomenal feat. We had started off phase 1 with a target of around 1,000 shots per day. We are thinking now with these mass vaccination sites and these things, we could be shooting for between 1,500 to 2,000 shots per day, which is about a 50 to 100% increase. We are doing all of this so that the maximum number of persons can have their first shot, because the numbers of COVID positive cases that we are getting now demand that we not keep that 40,000 in reserve unused for a month, 2 months. It demands that we change our strategy and we have to respond. But I want to reiterate what the Chief Medical Officer has said. Those 42,000 persons who got your first shot, you will be getting your second shot. No need to worry. We are just trying to vaccinate another 20, 30,000 persons, because the numbers and the hospitalization rates and the people on hemodialysis demand that we respond to the situation. So, Candice, that is my update this morning, and thank you for the past few minutes.
Thank you very much, Minister Dayal Singh. And as you know, we receive questions directly from the public via various means, phone calls and messages on social media pages. And we have some of the questions that have been repeated, and we want to get our subject matter experts to respond. The first question we begin with this morning is, can I get COVID-19 from the vaccine? And we go to Dr. Richards for a response, please.
Yes, hi, good morning, yes. So thanks, Candice. Very common question that is asked about if a person can get COVID-19 from the vaccine. The short answer is no. The Ministry of Health uses the World Health Organization's criteria for the use of vaccines in Trinidad and Tobago, and the WHO has a very strict and rigorous process to evaluate the safety and effectiveness of any vaccine that is being used. So, in summary, the current vaccines that are being used by the Ministry of Health in Trinidad and Tobago are very safe and effective to prevent COVID-19. So no, you cannot get COVID-19 from the vaccine. Thank you.
Thank you very much, Dr. Richards, and apologies for that little technical error. But Dr. Richards, we have another question for you, please. If I have mild allergies, can I get the COVID-19 vaccine? I'll repeat. If I have mild allergies, can I get the COVID-19 vaccine?
Yes, you can get the COVID-19 vaccine even if you have mild allergies. Now, there are some instances where a person is not advised to have to receive the COVID-19 vaccine, and those would be persons who have had severe allergic reactions or anaphylactic reactions previously to another vaccine. When you go to the health center, or to the vaccination site, there is a screening form that really tries to identify persons as an additional layer of protection in the event that they have some sort of reason to not be vaccinated. For example, a severe allergic reaction or an anaphylactic reaction. So, in summary again, if you have a mild allergy, you can be vaccinated. You will have a screening form to basically ensure that you are an appropriate candidate to be vaccinated. And so we would recommend that all persons who fit the criteria receive their vaccines to keep our population safe. Thank you.
Thank you very much, Dr. Richards. And another question that we receive quite often, persons are concerned if the vaccine will change their DNA. We do receive this question, as I said, quite often, and I think CMO will address this.
Hi, thanks, Candice. I think the short answer is no. So it would have been part of, I think, some conspiracy theories at the onset when they were developing the mRNA type vaccine in particular. So the answer is no. Having the vaccine doesn't alter one's DNA.
Thank you very much, CMO. And last question, how do I report symptoms after I take the COVID-19 vaccine?
Yeah, so just to remind the population of some symptoms that you would expect once you have the vaccine. People usually have mild symptoms suggestive, for example, pain and soreness at the site of injection. You may get fever. You may get general feeling of tiredness or lethargy for a couple of days. Usually lasts about 2 to 3 days maximum, and then it resolves on its own. If, of course, you have any of those symptoms that are concerning outside of that, you can call 877-WELL. That's 9355. Of course, you can also visit your nearest health center or get in touch with your private or public practitioner if need be. Back to you, Candice.
Thank you very much, CMO, and I hope that addresses some of the concerns in the public domain. And we go now into the question and answer segment for members of the media. As usual, we ask our media representatives, please state your name and the name of the media house that you represent. We ask for no more than 2 brief questions, and please ask both questions at the same time. We do have time constraints, but if we have additional time, we will come back to you so that you can pose an extra question. We go now to CL Communication.
Hi, good morning. Natalie Singh, Caribbean Lifestyle Communications. I'm referring specifically to the Ministry of Health press release yesterday concerning the Brazilian variant and additional cases of those. I was just wondering, what is the size of the samples that were taken, the total samples that were taken, so I could get an appreciation of to what extent the spread is happening. And then secondly, how does the increase in the Brazilian variant impact on this country's repatriation exercise? Thank you.
Okay, so just to give you an idea, I think we would have put out there that there were about 280 odd samples tested that were positive samples that were sent from TPHL to Caribbean Public Health Agency and onward to UE for testing. So that's roughly, it's between 280, it's probably gone up to closer to 300 by now. So that's the sort of sample size you're looking at. It's a very small sample size, but we have, as the press release would have indicated last night, we would have picked up 6 additional P1 type variants of concern, and there would have been 2 out of those 6 linked to previous P1 variants. So those would have been contacts that were positive as well, and then we send those onward for sampling. So that's a sample size. Your second question, just repeat it for me quickly.
How it affects repatriation?
Or how does it well, the repatriation exercises continue as planned before. I don't think really there's a significant link between picking up P1 and the repatriation exercise. As you know, through the repatriation exercise, we would have picked up 2 cases of the UK variant, and those persons would have been quarantined, isolated for the entire duration of time. Some of them actually having to stay as long as 33 days in isolation before we could have deemed that they were no longer infectious. So there's not a real relationship between picking up the P1 and the repatriation, at least at this time.
Thank you, CMO. And we go now to 98.1, please.
Good morning to you, Ms. Alcantara, and good morning to members of the panel. Stephen Cummings, 98.1 FM. My 2 questions quickly, one for Minister Dayal Singh and the other for Dr. Parasaram. Minister Dayal Singh, you mentioned some, seeing some disturbing sites. That was, I suppose, information that was brought to you about food vending sites. And is it now that roadside vending is on the radar of the Ministry of Health that could see some new regulatory focus? And secondly, Dr. Parasaram, we appear to be reporting the discovery, and I go back to the, to these new variants. We appear to be reporting the discovery of new variants as we talk about the Brazilian P1 strain. Yesterday, there were 6 recorded cases, and certainly with some measure of increased regularity. And I'm sure, with extreme apprehension in many quarters, shouldn't there now be a broader clinical discussion about variants in Trinidad and Tobago? Thank you.
Thank you. Thank you, Mr. Cummins. So I'll take your first question about focus on street vending. It is not about, in my view, it's not about blaming street vending or blaming bars or whatever. What we at the ministry are grappling with, and this is what countries around the world are grappling with, is human behavior. The inability of humans, wherever they are. Look at what is happening in India, Brazil. At this stage in the pandemic, 14 months now, to think that I am somehow immune, that I am somehow Teflon coated against the virus. And what is regrettable about all of this is that it is not limited to any one demographic or one socio-economic group. What we seem to be doing is living the national anthem, every creed and race find an equal place. Every creed and race in Trinidad and Tobago has abandoned personal responsibility. Every creed and race. Every socio-economic group. They have just abandoned personal responsibility. And when you abandon personal responsibility, you place the entire socio-economic health fabric of Trinidad and Tobago at risk. Let me repeat that. When every creed and race, every hue of Trinidad and Tobago, regardless of whether you're a gated community in the west, in the east, down the islands, Azessa, Awessa, Tobago, Trinidad, when you do that, you place the whole socio-economic fabric of Trinidad and Tobago at risk. So it's not about having food vending on the focus or on the radar. It's about appealing to individuals and communities to please accept the fact that we are in a global pandemic. Accept the fact, as Dr. Richards said, that for every 100 cases, 10 persons go into the hospitals, while only 2 come out. That's a net gain of 8. We cannot go on like that. Because every socio-economic group that has brought us to this position, when you want a hospital bed 2 weeks from now for your mother, your father, your grandmother, your child, it may not be there for you. So the conversation, once again, is about risk-taking and the personal responsibility. So if I am going to buy food, and I love street food, I love a gyros, I love a doubles, I love a whatever and fries. But if I go to my favorite truck or vendor and I see a crowd, I am not joining that crowd for 2 reasons. One, as Dr. Hines said, the infectious will infect the naive. And I don't want to get COVID. And if I have it, I don't want to give it to a stranger. And when you couple that, sir, with what I notice, and this is just my anecdotal experience, the number of people who are either not wearing masks or not wearing them properly is cause for concern. The front page of the Newsday today has a picture of 2 females walking down Frederick Street outside Excellent Stores with their masks down by their chin. When the law clearly says cover your nose, your mouth, and your chin. But forget the law. We are trying to get people to mask up to save their lives. It just makes good sense. It just makes good sense. And to prevent those 2 ladies on the cover of the Newsday from not landing up in a hospital and being a statistic. So that is my focus. My focus is on human behavior. Thank you very much, Mr. Cummins.
Thank you. And CMO, I think the second question focused on the broader clinical discussion.
The question, I'm not sure what angle in terms of broader clinical discussion. So what we have tried to do is bring a group of experts related to the genetics. As you know, we had Professor Carrington on, we had immunologists on to the press conference. Behind the scenes at the Ministry and the University of the West Indies as well, we are trying to learn, as is the rest of the world, as much as we can about all different types of variants from all over the world. And we would have looked on and saw, of course, India having the latest sort of variant of concern, which is a de novo sort of variant being developed in their country. So we learn what we can. If you meant in terms of a broader public discussion, that can be had later on, and I think that's the angle you were going at. So we can bring that to the public at a later date to discuss different types of variants, bring persons from University of the West Indies out in a forum where persons can have that chance to ask the questions that they wish to. So we'll take that into consideration, Mr. Cummings.
Thank you very much. And we go now to questions from AZP News.
Hi, good morning, everyone. Priya Bihari, azpnews.com. My first question is for Minister Dial Singh. Minister, I just wanted you to clarify in terms of the numbers of the vaccines, because when we got the first set of vaccine, that is the 2,000 from as a gift from Barbados, the 33,600 from COVAX, and the 40,000 from India, that adds up to 75,600. And we have vaccinated about 42,000. And now I think you're saying that we're going to vaccinate about 20 to 30,000 more people. I got the impression that the Prime Minister said we were going to use all of the 75,600 to vaccinate, to give people one dose. So can you just clarify that in terms of the numbers, and where would the second set of vaccines come from, the jabs?
Sure.
And my second question, Dr. Richards. Dr. Richards, I know in terms of the occupancy, the Ministry has said many times before that full occupancy would have been actually 75% of that total capacity. Can you give us an idea of the number of beds we now have, and at a rate of 8 patients going in hospital per day, at how long would that take, in other words, for us to have no more bed space? Thank you.
Right. Thank you, Prior. So I'll go over the math which I gave on Wednesday. Yes, so we got in 2,000 from the gift from Barbados, 33,006, as you said, from COVAX, let's call it COVAX 1, and 40,000 from India. That gives you a total of 75,600. You may recall I said we are getting about a 10 to 15% overage. So if you have a 10% overage from 75,600, that takes you up to 83,160 doses. If it's 15%, it takes you up to 86,940. Good. The balance that we have from SSI, CM is about 37,000 around there. So that's why I said we are going to try to vaccinate somewhere between 20 to 30, because we have used up some already, right? Where are the second doses coming from to vaccinate those persons who have received their doses? Good question. They are coming at this time from the COVAX facility. So COVAX 1 is already here. Just to make it simple, we were told we'll be getting 100,000 doses. COVAX 2, another 33,600 is due in early May, and then COVAX 3 so far is due sometime in June. And those are the doses we'll be reserving for second dose. And then we go after June, July, August to see what they are, what there will be in the market. But we have taken that decision, which the Prime Minister announced, and he was spot on, because of our numbers, that instead of having these vaccines lying down there, it is better to get as many people up to about 60-70% vaccinated. It's better to have 70,000-80,000 persons with their first dose than 42,000 with their first dose and the rest just waiting there. So that's the decision, and those are the numbers. And COVAX 2 will be here sometime in May, and then we look out for COVAX 3. So I hope that answers your question, Prior.
Thank you, and we go now to Dr. Richards for a response to the second question.
Okay, thanks, Prior. Nice question on models and predictions and forecasting, which we, of course, do at the Ministry of Health. So as of yesterday, we had approximately 417 hospital beds in the parallel healthcare system across 7 hospitals, representing the HDU beds, ward level beds, and ICU beds. We have, as of this morning, gone over 500 beds, given an increased operationalization exercise involving AREMA, additional beds at Covet. And another factor has been the shift in the Augustus Long from being a suspected to a confirmed hospital bed. Now, you asked a very interesting question in terms of projection and trends, given the statistics that we gave in terms of the net gain of 8 persons per day based on 100 new cases per day. And now, the projections are not a direct mathematical projection that we'd be looking at, but there would be some variables that we would be looking at in terms of the levels of care, in terms of facilities at other hospitals, testing, and so on. But if we are to really use the figures of yesterday, which would have 183 persons in hospital as of last PM, and we look at today's capacity, which is on average 500, we are looking basically at roughly 300 spaces being left. And that can, given that current rate, with all things being equal, at a rate of, let's say, 100 or an average of 100 cases, 150 cases a day, the beds can actually be diminished or be utilized within 3 weeks to a month, which is, of course, a very concerning trend. Now, what I will say to the population and I will say to the media is that this trend can be curbed. We are seeing a very disturbing trend where the parallel healthcare system may not be able to be as resilient or as supportive as it has been over the last year and 3 months since it was operationalized. However, if we start to and we continue to practice our COVID-19 prevention measures, we can see a de-escalation or a decreasing rate of hospitalizations given the incubation period of the virus and the time that we can take to turn it around. So thank you, Prior.
Thank you very much, and we go to Minister for some additional information.
Yes, thank you. I just wanted to send a message. Maybe it hasn't reached to the religious community. We have amended the regulations, and now, because different religious leaders had reached out to me about live streaming of services, since we had closed places of worship, you are allowed to go into your places of worship, churches, mosques, mandirs, temples, wherever, and do your live streaming of your services with 5 people or less. So this is the position we had last year, and that is now in force. So please go ahead and do your live streaming, especially now in the holy month of Ramadan. And I also want to send out a particular thank you to the Muslim community. In the holy month of Ramadan, literally smack dab in the middle of it, that your mosques were in fact closed, and you took it in the spirit of nation building. And I want to thank all leaders of the Muslim faith for really accepting that decision. We know it's a hard decision, but when I spoke at a function in Kakandi Road and Felicity just before the start of fasting about 3 weeks ago, I really praise the Muslim community for their discipline, and I want to thank them again for seeing this measure for what it is, one meant to save lives, as all the public health measures are. Thank you very much.
Thank you very much, Minister, and I know that gives some clarification to persons of different religious backgrounds. We go to questions now from CNC3.
Hi, good morning. Fanny Bray from CNC3. I have 2 questions. I heard and I understand the call that we need to exercise public personal responsibility in the rising cases. But surely there's another factor. My question is actually to Dr. Avery Hine. Have you noted, what do you account for this sudden, dramatic, exponential increase in infections? Public irresponsibility aside. And my second question is probably for the CMO. Our newsroom has reports that a Venezuelan national has given to a child at San Fernando General, and both she and the child have tested positive. Are we able to get any information on that?
So we go to Dr. Hines to respond to the first question.
Okay, thanks for the question. Now, you already partially answered it, and I'm not sure that you realize. Now, once you have a number of cases in the population, a certain level of circulating virus, and you have enough people who are infectious and unaware and still moving around, or infectious and aware and still moving around, then you do have that rapid explosive growth in numbers of cases. That exponential rise that you mentioned is the natural sort of sequel to having circulating cases in the population. At first, it seems like they're very few, and then as that number of infectious people in the population continues to grow quietly, it suddenly gets to a point where you see several times the number appearing from day to day. That's that exponential rise. As one case gives rise to 3 or 4, and those 3 or 4 give rise to 3 or 4 more. So the sudden rise that you're seeing now would be, to some extent, the consequence of the previous levels of viral circulation driven by the previous levels of activity and adherence, or the lack thereof. So that explosive growth that you're seeing is really driven by viral dynamics. That's how viruses work in an epidemic setting, in an epidemic situation with lots of susceptible people. You move from seeing relatively few cases to suddenly seeing massive, almost unimaginable numbers as that exponential growth in the cases manifests itself. So really and truly, and what's very important about this is the only way that we can actually put a damper on that exponential growth is to separate infectious people from people who can be infected. And we separate them by removing the ability for them to come into contact with each other, either by asking those who are symptomatic and know that they're symptomatic to stay out of circulation. Those who are symptomatic and ill, those people are put into isolation in a hospital. Those who are not symptomatic, the other public health regulations that we keep talking about, the mask wearing, you don't have to feel ill to wear the mask. The mask wearing will help those asymptomatic, not knowing infectious people to reduce their risk of transmitting. The physical distancing, not gathering in crowds, not coming together at this point in time. These are the things that are actually going to put a damper on that exponential spread. Right now, what we need is to reduce the probability of contact of people who are ill and infectious with people who are not. So this is why, again, we're reinforcing the call to have everyone reduce your movements, reduce your mobility as much as possible. That shelter-in-place concept. Don't go out and interact with people outside of your household at this point in time unless you really have to. Because these random probabilities, you get into contact close enough to someone who is infectious, you don't even know, that probability is now higher at this point in time as the caseload in the population grows. So the growing caseload drives that speed, that exponential increase, and the counter to that is to keep people away from each other so that we can get a break in that transmission. I hope that clarifies that question.
Yes. So your second question, I don't know. Basically, as you know, and we always maintain patient confidentiality, and we can't go into details of any individual, but just to assure the public in general that, of course, if you are COVID positive, whether you are national or non-national, you will be given the same level of care. It is a public health disease. As a non-national will be given the same level of care as a national would be given COVID or other public health disease. So we can assure the population in general that that will be so, and the containment strategies will be the same as well.
Thank you very much, CMO. We go now to questions from Newsday, please.
Good morning, Janelle D'Souza from Newsday. When it comes to the out-of-the-ordinary responses to the vaccine, what are the clinical protocols to deal with people who have concerns, and what policy directive has been given to healthcare workers at public health facilities to treat with actual adverse effects? And my next question is, what is the plan to vaccinate people in elderly homes? I've heard that there have been no vaccinations there as yet, as well as people with mental disorders like Alzheimer's and dementia and so forth.
Okay, so thank you for the question. So it reminds me what we said at press conferences in the past, and I have the document here. I asked for some research to be done into the issue of mental health conditions and vaccination. The issue becomes one of informed consent. I have a grid here which I spoke about some time ago. We got policy positions from Australia, Canada, United Kingdom, United States. We are looking at it. On the issue of the homes, again, I would have indicated months ago, it's a question of informed consent again. And I have Dr. Rohit Doon working with the association to go into those facilities to vaccinate those persons who we could vaccinate. The risk with those homes, and this is where I am urging the media to have a heightened sense of responsibility. You may recall about 2-3 weeks ago, there was the unfortunate link in the media about the vaccination and 2 unfortunate deaths, which were never linked. And I did say many months ago, people in homes are in the sunset of their lives. And when we start to vaccinate persons in homes, I am asking, begging, and pleading that many of these persons, and let me choose my words carefully because they are in the sunset of their lives. How do we report on an elderly person in a home with or without vaccination who unfortunately passes? Persons in homes are severely immunocompromised. They are very aged and very old. And when we start to vaccinate them, and Dr. Doon is working on that, and you have an inevitable passing of an elderly person, I hope we don't jump to the conclusion, as we did 2 to 3 weeks ago, in the face of no evidence, that the person in San Fernando, which is unfortunate, and the Frankie Khan issue, that it was due to the vaccine. That is a big fear that we have in health. So we will do it, but very selectively and very cautiously. Thank you very much.
Thank you, and to CMO for response to the first question.
Yeah, so side effects for the COVID-19 vaccine are very similar, to the most part, to any other vaccine that is administered through the expanded program of immunization. The clinicians are well trained and well positioned to deal with those side effects, which are usually, most of them, mild, very mild. Some of them, for example, anaphylactic type reactions. We have all the systems in place and training to deal with allergic type reactions in the health system already. So the majority of the conditions, persons are well trained and have been dealing with it for a number of years, and it's part of your normal medical training for the physicians that come out of any institution. So I don't think we have circulated as well the UK guidelines for that particular syndrome, VITT, to the clinicians so that they are aware of how we treat that particular instance of that rare complication. Outside of that, generally speaking, the guidelines hold the same for most vaccinations that we offer in Trinidad and Tobago.
Yeah, let me just come in here again. Yesterday, well, not yesterday, on Tuesday, I asked the Director of Women's Health, Dr. Adish Sirju Singh, to host a local panel of experts, which we did yesterday. Bearing in mind the recent people are trying to make the causal link between strokes, thromboembolic events, especially in women. You had the Johnson & Johnson vaccine being suspended. So we did not ignore the recent events. We hosted, and I was part of it, expert panel made up of the Director of Women's Health, Dr. Sirju Singh, Chief Medical Officer, myself, the University of the West Indies, Trinidad and Tobago Medical Association, chiefs of staff from all RHAs, inclusive of Tobago, local private sector OBGYNs, to discuss this issue of adverse events that are being linked to the vaccine, especially in women under the age of 50. That discussion was held yesterday, and and inclusive of Dr. Kenneth Charles, the hematologist attached to the Ministry of Health. That report with suggestions to do just that, what you are suggesting, the reporting of these events, not only reporting the identification, the Dr. Ian Sammy of Tobago made a very good point. Even if it's 1 in a million, how does the A&E recognize it and treat it? So that report, which I asked for yesterday, will come to me hopefully by Monday. And I really want to thank the private sector, OBGYNs who participated, TTMA, and every local expert, UE, everybody who gave of their time and expertise. So that position will come to me because we must have a local position to advise our women how to make the proper personal choice in whether to take the vaccine or not, even though it's a 1 in a million. For that one person, it's going to be something of concern. So we are taking this whole issue of reporting of adverse events very, very seriously, especially with our women under 50. Thank you very much.
Thank you everyone for joining us today. We have come to the end of today's media conference. Please remember to wear your mask.